Hello and welcome to the webinar, Near-Infrared Spectroscopy in the Management of Critical Limb Threatening Ischemia. I'd like to thank you for joining us. I'd also like to thank our sponsors of this educational event, the new Cardiovascular Horizons and Kent Imaging. I would like to introduce and provide a warm welcome to my co-host of this webinar, Dr. Craig Walker. He's well known to all of us on this webinar. He's a close friend of mine. And as we know, Craig is the founder and president of the Cardiovascular Institute of the South. He's also the founder and chairman of New Cardiovascular Horizons. Again, thank you to NCVH for sponsoring this webinar tonight. Craig will be coming on in a little bit. First, I would like to provide a very brief overview and agenda for tonight's webinar. I'm going to introduce you to near-infrared spectroscopy, the technology behind it. And then also discuss very briefly some clinical utilizations, primarily on the wound care side. I will then turn the gavel and the podium over to Dr. Walker, who will really give us a good overview of the use of this technology and how he is integrated into his vascular program. He's going to review some case studies, and then we'll both be back to provide a Q&A session at the end. So what is near-infrared technology? Near-infrared technology is based on measuring and analyzing light in the near-infrared spectrum, primarily between 700 and 1100 nanometers. This technology has been around for a while. It was developed in the 70s and had a wide range of applications back in the 70s, primarily industrial. But based on the fact that they've been able to downside the device and make the chips to make these imaging devices smaller, it's moved into the medical arena. It's not hyperspectral technology. It really focuses, again, on the near-infrared spectrum, a small portion of the entire electromagnetic light spectrum. And this technology essentially images in that near-infrared spectrum, and it is able to differentiate oxygenated hemoglobin from unbound hemoglobin. Unbound hemoglobin will have an absorbance at about 750 nanometers, versus that hemoglobin that's oxygenated absorbs at 850 nanometers. So what happens? Well, the camera shines light into the tissues. It analyzes the oxygenated hemoglobin and the deoxygenated hemoglobin. Those spectrums are compared through very sophisticated computer algorithms within the camera. The data is then processed and it provides an image and allows us to actually look at tissue oxygenation. Here's an example of how the technology works. These are some of my images, pre and post hyperbaric, a single hyperbaric treatment. But if you look at the image on the left, you see a lot of blue, green, not very intense reds and yellows. After one hyperbaric session, immediately once the patient comes out of the chamber, you can see the robust increase in oxygen saturation, as would be expected with hyperbaric. But you see the image on the right showing very rich red and yellow colorations, suggesting very significant increase in tissue oxygenation. We need to interpret these images, however, and that can be challenging. There are a lot of factors that influence and provide either low oxygen saturations or high oxygen saturations that you would imagine. Those patients that have decreased oxygen supply, increased extraction, such as seen in hypermetabolic states or inflammatory states, are going to have depressed oxygen saturations. Whereas those patients that have increased oxygen delivery, maybe after revascularization, or as I just demonstrated through hyperbaric, those images are going to reflect very high oxygen saturations. And when looking at these images, you need to understand what you're seeing and how to interpret that so that you can make the best clinical correlation of the images to your patient scenario. I'd like to just walk you through how I have used this near-infrared technology in my clinical practice. We use it in a number of settings. Dr. Walker is going to share with you some extensive information on clinical evaluation assessment, how he uses it in his practice. We have other surgeons out there using it for intraoperative and surgical evaluation of their patients, especially in breast reconstruction, bowel surgery. And then I have a lot of colleagues who are using this technology in wound care. I've certainly had extensive experience using it to evaluate wound bed preparation following debridement. This is incredibly important prior to cellular and tissue-based product application. We can use it prospectively to evaluate the wounds, and certainly a number of different indications, such as I've just demonstrated the use in hyperbaric oxygen therapy. Here's an example of using it in debridement. You can see those images on the left, the RGB images. And if you look at them, you can see certainly a contrast between pre and post debridement. However, when we compare that with the images generated from the near-infrared camera, snapshot, you can see how that debridement has really augmented the tissue oxygenation of that bed, stimulating that wound bed, prepping it for additional therapies such as CTP applications. This is a device called OxyBand. It's a transdermal oxygen delivery device, and this shows how near-infrared spectroscopy can evaluate this technology. You can see again the robust jump in tissue oxygenation based on hemoglobin saturation, pre and post the use of this transdermal oxygen device. And again, I think this assessment is fairly profound. Again, looking below the surface of the wound, looking deep into the tissues. We're focusing on peripheral arterial disease in this webinar. I wanted to show you another application. This is using an ART-Assist device. Most of you are familiar with it. Here's a patient with a Wagner 3 diabetic foot ulcer that did not want surgical amputation. He was not a revascularization candidate, so we used the ART-Assist device. Over a period of time, you can see the nice improvement in tissue oxygenation. That patient healed his wound very shortly after this, but if you look at the images, you can see what that ART-Assist device is doing to the wound, the peri-wound tissues. There you see his healed image. You've used it extensively in hyperbaric therapy. Here's an example. This is a patient with some frostbite. You can see those dusky tips of the digits, digit 3 and 4. Pre-hyperbaric, it correlates very well with the camera, again, showing those blues and greens at those fingertips correlating with the tissue demarcation. Do we make a difference in hyperbaric? Well, here the patient comes out of the chamber, post-hyperbaric and RGB image. Yeah, maybe we do see a little bit of improvement, but I'm not really sure. However, Snapshot can really assure us that we're doing the right thing. You see that robust increase in tissue oxygenation, patient had a very successful outcome. And we use it in all categories of hyperbaric indications to gauge the progress and the treatment response. We can also look at those patients that do not respond. This is a publication, poster publication that my son Jonathan and I collaborate on, looking at a series of patients, suggesting that by using the camera you can look at pre and post dive data and make judgments of whether those patients will respond or not. I think this will be very helpful in guiding our hyperbaric decision making as we move forward. Here's an example of one of those patients. You can see the top RGB image, lower image, and really can't tell much from an RGB standpoint, but looking at it pre and post hyperbaric intent, you see the nice augmentation of tissue oxygenation. This patient had a great delta between pre and post hyperbaric based on the digital scores from the camera, and this predicted healing. We also have decided we can use SnapshotNIR to evaluate patients when all we had before was transcutaneous oximetry. As you know, there are many challenges with transcutaneous oximetry. This has been the mainstay treatment in guiding some surgical decisions as well as predicting wound healing. And we have done some evaluation, as have others, where we've compared transcutaneous oximetry values to that obtained with Snapshot. The correlation is very tight, and I think that this is going to be much more efficient in getting data to determine tissue oxygen saturations as opposed to the old TCOMs. And we have actually talked about this on podium presentations and multiple poster presentations. So I feel that from a clinical surveillance standpoint, my experience suggests that you get immediate feedback on tissue response. You can look at patients at a single snapshot or over the course of multiple interventions. I think Dr. Walker will talk about his interventions from a vascular standpoint. This prospective monitoring is very helpful in clinical decision making, and I think this camera, as we get more data, will suggest that we can use it for prognostic imaging based on the camera's evaluation of tissues. We can predict whether patients will do well or not do well. The advantages of NRS snapshot technology is certainly decreases the time of assessment. Just in comparing TCOM, which takes 45 minutes to an hour, this is a 1-minute imaging device. You interpret, you have that data much, much faster. You certainly have no disposables in the use of this device. It's non-invasive, very low burden to the patient in the clinical setting. And again, I like it because it provides insight to bedside evaluation, interpretation to enhance decision making. So I'd like to thank you. I hope you enjoyed this brief introduction to the technology. Now we're going to hear the real story. We're going to hear how Dr. Walker has used this technology in his clinical practice to enhance his care of vascular patients.
Hi, it is my pleasure to follow Dr. Niezgoda to speak about the clinical utility of Kent Imaging System. I'm Craig Walker from the Cardiovascular Institute of the South. Now, where do I use this system? I use it to determine if there's an ischemic component to a foot ulcer as preoperative evaluation prior to Charcot foot surgery, as prior to revascularization to serve as a baseline to determine whether or not conservative measures may heal the wound or ulcer, and as post-vascularization to assess adequacy of perfusion and to evaluate for re-occlusion. Now, these are some examples of cases where I found this to be very helpful. This is a 64-year-old male with coronary artery disease and an ischemic cardiomyopathy. He's diabetic, long-standing. He's a smoker and he's hypertensive. He's had his right leg previously amputated. He's had multiple bypass surgeries with a fem pop bypass and 2 distal bypass surgeries on this left leg. And with that, he had developed a large non-healing foot ulcer with gangrenous skin changes of the tip of the hallux. He had 6 months of wound therapy in a wound healing center with worsening despite 3 months of hyperbaric therapy. He had no ischemic cardiomyopathy affecting flow. Here we can see the study shows that the patient has very poor oxygen saturation of the foot. And I think it's realistic for us to assume that healing is unlikely without some form of flow restoration. So this patient did have an aggressive intervention in which we opened up and occluded SFA and infrapopliteal arteries. And I saw him in review 1 month following treatment of his SFA, popliteal, anterior tibial, and posterior tibial arteries. By this point, he had healed the hallux skin changes except for the very dorsum tip of the foot, and that's shown here with the question mark. But the large foot ulcer was almost totally healed. He was having no pain. And you can see the entire rest of the foot has very high oxygen concentrations. Certainly, this is a successful and durable outcome in this patient. Or this lady who presented to me at age 98. Now, she was a very interesting woman because I'd first met her at age 93. Her story was that she had severe coronary artery disease and atrial fibrillation. Very viable woman, certainly the person in control of her family. She had had 2 failed tibial bypass procedures 6 years before I first met her. And then 5 years before I took this picture is when I met her at age 93. And at that moment, she had a large ischemic foot ulcer and rest pain. She still had non-healing surgical wounds from the distal bypasses. And so I treated her with stenting of the calcified superficial femoral artery, popliteal artery, TP trunk, and she had no occlusion of the anterior tibial and posterior tibial. This was an extraordinarily difficult procedure, taking approximately 3 hours to perform. She had done very well for 5 years, and at age 98, she came back again, still mentally viable, doing well. And she told me that she was noting some claudication. Her duplex was equivocal. It showed only mild SFA in-stent restenosis. I could not see through the stent in the tibio-perineal trunk, but she had monophasic perineal flow, and this was the only flow to her foot. So I was concerned, could this represent ischemia? So we took a Kent imaging picture, and here you can see she's got plenty enough flow to her foot to where we don't have to do anything. Certainly, and so what we did was, despite no palpable pulses, no intervention was required at this moment. And certainly we don't want to intervene on 98 years old patients if we don't have to. She was treated with low-dose cilostazol, had complete symptom resolution, and I was able 2 years later to celebrate her 100th birthday. She is still alive, so we'll see where we go futuristically. Or this patient, a 67-year-old diabetic with end-stage renal disease on dialysis with extensive coronary artery disease, carotid disease, and a gangrenous distal tip of the hallux. Patient had had failed distal bypasses 2 months prior. He was referred by his vascular surgeon, who had also done his AV graft work, for possible revascularization, which he thought was improbable for success, or to determine which level he should amputate. We brought the patient to the lab and we performed orbital atherectomy of the severely calcified femoral and popliteal artery, following which we placed Supera stents. We also then performed orbital atherectomy of the anterior tibial and posterior tibial arteries, followed by angioplasty, achieving excellent flow to the foot. So this patient then had 2-vessel flow to the foot. Now we can see here our initial foot study showed very poor flow to the foot, unlikely for the patient to heal. 1 month later, I saw the patient, and most of the foot was healed. Things were looking better, but we can see that the patient has excellent flow to the foot and excellent oxygen concentrations. And certainly this gave us solace that the patient had good flow. The surgeon actually decided not to amputate anything and just to wait. And ultimately, the gangrenous skin changes on the hallux completely, that area fell off and he was completely healed. And right now he is 18 months post-surgery and has had no further problems. So in conclusion, I found this to be a very useful tool in my experience. First off, it's very easy to use and it gives reproducible information. And in the past, that was hard to get. Easy to use devices that gave us reproducible information. This device has become my go-to evaluation tool prior to and following critical limb ischemia intervention. I found the device to be a vital tool in longitudinal follow-up of patients with critical peripheral arterial disease. And I believe that this device is extraordinarily helpful in the evaluation of patients prior to extensive foot surgery. With this, I will conclude my talk, and I look forward to the upcoming panel discussion. I thank you very much for your attention.
Thank you so much for joining us. I appreciate your collaboration.
My pleasure. This is a great opportunity to discuss something I really have found incredibly useful in my practice.
Well, I loved your cases. I think they're really insightful, and just it clearly speaks to the experience that other clinicians are seeing in other areas of medicine. I've had great results in the wound care realm. It's great to see that, you've got some predictability there. And one of the things that we always say, Craig, and I'd like your opinion on this, is that this tool, I think, is certainly requires more research, more data. There's no doubt about that. However, the data that we do have, the preliminary results we do have, is suggesting it's helping us to guide our clinical decision-making. And I saw a couple examples where you possibly avoided an amputation in these patients.
Yeah, I've used this as a guide to know if I have to do more or if we have adequate flow. And thus far, it's really been incredibly useful and its predictability has been superb. In the past, Jeff, I've tried many different tools, and part of the problem that I had, they were not reproducible. They were very technique dependent, very tech dependent. This is none of those things. This, I typically get a reading within a minute of requesting the study. The reading is completely reproducible time and time again. And I made a point, in fact, in several of these cases, to simply reproduce it 4 or 5 times just to see, would it change within an hour's period? And it was exactly reproducible time after time. And I don't have to have techs who have 10 years of training to use it. This has been very helpful. And frankly, I was surprised at how incredibly useful it has been to me.
Just to speak to what you're saying, I can even do a snapshot image, and imagine if I can do it, yeah, anybody can do it. So, listen, Craig, again, thank you so much for your presentation. We have quite a few quite a few listeners that have joined us tonight on the webinar. I'd like to extend my thank you to all of them for joining us. And if you do have questions, we are certainly available to take those questions and hopefully provide you with an answer. And those questions can be sent to ask questions in the chat area. So feel free to fire away. Brad, the first one that has come in, and we've just sort of referenced that, but obviously, I think it's helping our clinical decision making. But how about even going a step further? Do you think that there's some prognostic ability in these images to actually predict if the patient will heal or not? What are your thoughts on that?
I think definitely it's helpful if we're dealing with pure ischemia. There are many reasons a wound may or may not heal, and blood flow is, of course, one very important reason, but not the only reason. But in terms of ischemia, which is what I deal with, and restoring blood flow, I've been very impressed with this being very predictable. If I have seen oxygen saturations usually above 50 and certainly above 60, I'm yet to see a wound that has not started to heal and do better. Now, that may not be appropriate if there's deep infection. That's not where I am typically brought in. But in terms of as a measure of have we delivered enough blood flow, I think it's very good. And, often in the past, we would sometimes bring a patient back and study them if a wound was not healing, just because we weren't sure. Were we getting enough blood? Here with this, my experience has been that if I see oxygen saturations in the area of interest above 50 and certainly at 60, I've had none of those have regression of healing. And so I've found this to be very useful. And as I said, I view this as one of the biggest advancements I've had in following patients with critical limb ischemia.
Wonderful. And, Craig, I did throw a slide up about, our correlation with TCOM. And, there's a fair amount of data in the literature on TCOM and looking at what values of transcutaneous oximetry will predict healing and good outcomes. And, we found a really tight correlation between near-infrared spectroscopy and the TCOM. So I think that makes sense based on, what's available to us in the literature. So, and I agree with you. Those numbers get into the 60, 70 range. I feel pretty comfortable about that. Yeah. So, Craig, here's a question for you that's come in. Dr. Walker, have you had patients post-revascularization that have appeared patent by Doppler but still show some tissue hypoxia by camera?
I have. I have seen that. I've also seen a couple cases, because I do sometimes look at this immediately post-procedure, who do not appear to have quite the O2 sat that I've wanted, yet I thought the result looked good. But when I would study them the next day, so I've followed this more than I might just clinically, right. I've actually seen it improve in some of those cases within a day or two. A couple of the ones, though, that I did not see great oxygen saturations, I'd opened up the major vessels, but they were typically patients who had this sad disease of the foot, or the small arterial disease, where all of the small branches, the not named arteries of the foot, had diffuse disease. Even in those, though, often if we'd opened up the inflow to those, we might see some improvement in O2 sats, but just not to the levels that we wanted. But I would caution, sometimes it takes a day or perhaps even two before you determine exactly what's going to happen fully with O2 sats in the foot. Have you experienced that as well?
Well, it's interesting. The findings that we've seen in ROBL kind of walk right along those same lines. And patient comes out of the lab, and typically I know the temperature is turned down. These patients are cold, and what we've started to do is we'll take one of the blankets from the blanket warmer, wrap it around their leg that we're interested in, and then image them an hour or two. They're having to sit there anyhow, so we'll rewarm the extremity, and that has shown a nice change. So that you're getting better images in a nice warm extremity than you would in something that might be vasoconstricted from the cold. But you're right. After a day or two, you're starting to see more of what you think you're going to see. Craig, in the past, and this is kind of an interesting question, I guess, we would send patients for interventional therapy, and they'd come back after an intervention. And sort of the mantra was, let's wait at least 3 weeks to allow this intervention to mature before we make a decision on amputation or what else we're going to do. Do you still ascribe to that? And does this, does a snapshot maybe allow us to make decisions a little earlier?
Yeah, I do not ascribe to that theory anymore. Part of that was because our earlier studies were not so reproducible. Really, I'm going to tell you, at least in my experience, and again, it's related purely to the vascular component. I think within a couple of days, we know where we're going. We know if we're improving to start with. Improving is a big thing. And certainly we have some absolute measures when we look at this. And as I said, if I see an O2 sat, even in the 50s, my belief is we're going to get healing with that. And that has been what I've seen. Certainly, once we hit 60s, from the blood flow perspective, we have what we need. And so I think this has really changed how I look at procedures. I'm less apt to bring a patient back earlier. And that's simply because I have seen just a little bit waiting and continuing with therapy, we start to then see healing at that point. I've really changed the way I treat patients based on this tool. And I must say, I came into this very skeptical.
Sure. Yeah.
I didn't walk into this thinking, gee whiz, this is something that would change what I do. I've been long looking to determine, have I achieved adequate perfusion? And as you know, that's hard to know at time zero. This has probably been the tool that has allowed me to most closely do that.
Yeah, and I shared your skepticism at first as well, and we put this this device certainly through the trials and ringers, and obviously sitting here in the role I am now, I'm a confirmed believer, and I think it's a game changer. So let me ask you about your thoughts on angiosomes and using this camera to actually image angiosomes that you've targeted.
Very important. Obviously, angiosomes, I think everyone listening knows it. An angiosome is a three-dimensional block of tissue supplied predominantly by one vessel. And typically, we have connections between angiosomes via choke vessels. So often, singular vessel to the foot is all we need. But there are some patients who might have two great vessels to the foot, and yet one angiosome, one block of tissue, can be critically starving for blood and can in fact have gangrenous changes. I think once again, this is very good in telling us which vessel to pull. I had unfortunately lost a couple great images that I would have loved to have showing exactly that. A patient whose one vessel out to the foot was a posterior tibial who had a massive ulcer. And you could see this go from O2 sats that were very difficult to see anything to having sats that hit 84 after we opened up this area. Unfortunately, in turning off the machine, we lost that image. I did not have it to show on my pictures. But once again, once we saw that increase, we knew exactly what we had done. And that patient went on to have very rapid healing of a large ulcer at the ankle area.
Excellent. Got another question that's coming from the audience, Craig. Again, love your thoughts on this. Can you use Snapshot and these images as a tool for screening for perfusion instead of what we've used in the past, ABIs? What are your thoughts there?
It depends what we're looking for in the screen. If the screen is a wound going to heal, I think it's probably pretty useful for that. In terms of detecting peripheral arterial disease, we can have significant peripheral arterial disease and not yet necessarily have a wound. And so in that sense, I don't think we can use it in and of itself. I mean, unless, of course, we have incredibly poor oxygen saturations. But it is a tool that I'm incorporating in a big way. I want to know if I intervene on someone, have I embolized to any part of the leg? Okay, have I done other things? So I like an image with this ahead of time, because if during a procedure, even if I've achieved good flow, if I may have embolized to a little area, I would like some clue of that. I like that as I follow the patient to see what's happening to wounds or ulcers or things such as that. But I'll tell you, I use this a lot to determine if I have to go back in. As we know, peripheral diseases progress. These patients in particular with horrible infrapopliteal disease often require a secondary intervention. And I'm really using this to guide when I have to go back in. I found this to be very useful because sometimes that is a real hard decision to make.
Mm-hmm. Right, right. And just to kind of, again, echo your comments, I think, the answer to the question is, can we use it as a screening tools? At this point, we don't know. We are actually looking at some data and some studies to collect that information and to see if it is all predictive and using, it early on as a screening tool. Most of the data we have right now is wound related, like you said, Craig, and I think we really have a good sense of the value there. But looking at it from an ability to replace TCOMs, no doubt. But as far as ABIs, I think we got some more work to do, and the jury is still out as far as that's concerned, for sure. Craig, another question here is, what do you think about using the technology to differentiate venous from arterial ulcers?
That's a great question. I think that's, obviously those typically look different. Arterial ulcers are typically bland, they're typically more distal, but it certainly can give us some ideas. Obviously, if you're seeing great O2 sats, it's highly unlikely to be an arterial ulcer. But Jeff, if I can turn that question around just a little bit, one of the thoughts I've had about the use of this device in terms of research that I'm planning to try to look at is, what impact might treatment of venous disorders have on healing arterial ulcers? At least theoretically, a capillary perfusion bed's perfusion is the difference between the mean arterial pressure entering that bed and the back pressure, the venous pressure on the back side.
Right.
Therefore, anything increasing that driving pressure within would raise that perfusion pressure. But theoretically, might we improve things if we simply relieved venous pressure on the back side? We don't have great data yet ever looking at that. But one of the things I am considering doing is looking at this in venous interventions in patients who have ulcers where we think it could be a combined ulcer, or they might have issues, and determining, does fixing just simply the venous system, does that improve capillary perfusion to the point that perhaps we improve oxygen saturations? Purely theoretical, but I think certainly very interesting, because that may be one additional means by which we can help patients.
Craig, I'll tell you a funny story. My son, Jonathan, as you know, is working in the clinic with me, and he's hoping to get into medical school at some point. I hope he's not on the webinar. Actually, I hope he's on, but I hope he doesn't hear this. So Jonathan, plug your ears. The kid's a lot smarter than me, Craig, a lot smarter than me. Mm-hmm. Anyhow, he's done a lot of work with the camera. And he came to me one day and he said, Dad, look at this. This deoxygenated hemoglobin view. I think there's some value here in looking at the deoxygenated hemoglobin view in venous patients. And I'm like, what are you talking about, John? He says, well, as we treat them, whether we, treat them adequately with compression, or, if we do fix, fix them from a insufficiency standpoint through some form of ablation or procedure, he says, look at Dad, the deoxygenated hemoglobin starts to become less, meaning that, there's not as much, like you were saying, Craig, back pressure back, and so you're improving the stagnation state, if you will, that you see in these patients. And that is correlated nicely with healing of these ulcers. So I think that we're going to see the same thing, that you're suggesting in the arterial patient, as well as correlating that to the venous patients. How well are we removing that stagnating blood from the extremity, and to what degree? So it's a very interesting area.
Sure. And I mean, think about the implications. You have many patients where you really don't have a good arterial option. If those patients have combined venous disease, might relieving that back pressure improve that perfusion of the capillary bed? Again, it's purely theoretical, but at least based on physiology as we studied it, it should make a difference.
It makes a lot of sense. It makes a lot of sense. Let's see here. Here's another question that's come in. Could you comment on intervention prior to source control? I feel that the vascular side needs to be addressed prior to any aggressive debridement, amputation, or reconstruction. Well, we've started already talking about this, Craig, but you can probably comment again as to, should we be considering this technology prior to making interventional decisions?
Well, I think it certainly helps. I guess that question would relate to, for instance, should one go in and start major surgery for Charcot foot without having some assessment of vascular blood flow? And I think probably it is better before we cut into the foot if we can make some form of vascular assessment. I think most of us would agree that wounds don't heal well if there's not good blood flow. And of course, you can get ulcers just from Charcot foot, the neuropathic reasons, the pressure reasons, et cetera. But I think historically, it's been so hard to really ideally assess just how good blood flow was to the foot. Again, I cannot emphasize enough until one sees how this procedure is done, how easy this is and how reproducible it is. There are lights that come down, and when you make these lights all focus as single points, you then take a snapshot picture, and it's honestly that simple and that reproducible. And my then question was, okay, well, that's easy, but will it really hold up? Will the correlation be there? And I've been very impressed in that it has. I am yet thus far, and I've been working with this for over a year, to see a case of a O2 sat of 60 where wound healing did not occur very well. And so I am very impressed thus far with what I've seen. I think we need larger studies, of course, but I think this is going to become a very key part of the therapeutic armamentarium, and certainly before making a determination. Let's say, for instance, am I just going to cut a toe off, or am I going to do a transmet, or what am I going to do? I think it's important to know blood supply. I think to simply amputate and not know whether or not you have enough blood supply to heal is a fool's game. I think it's very important to know what you can do. As I showed you a case, the surgeon sent that case not thinking we had a chance of getting blood flow. He says, please try. I think there's no chance you'll get blood flow. Well, luckily we did. But his real question was, do I take a toe? Do I take a foot? What do I have to take? And I think that's the right questions to ask. I think it's the way to do this, because you don't want to take a toe and then another, a little higher and then a little higher. That is expensive. It's bad. It's debilitating. It's bad outcomes. And so I think assessing blood flow up front is very important.
Absolutely. We sort of talked about this, Craig, but I think it's an interesting question. They're asking, what do we find more important, the absolute oxygen values or the StO2 values, or the change in numbers? I've got my thoughts, but I'll let you take a crack at it first.
Yeah, I have used absolute numbers to help me. I've mentioned a number of 60, where thus far that number is very important to me, because at that point I am yet to see a patient, if we achieve that, not heal. I will tell you, even amongst the 50%, 50%, I've seen overwhelmingly most of those improve, particularly if they had started off at a very low level. In that situation, I think the change makes a big difference. But I can tell you, for me, an absolute value of 60 or above is really something that I'm very comfortable with. Jeff, would you agree with that?
Yeah, absolutely. I think that is a magic ballpark number, that 60 cutoff. I think it's very important, and I think you're right. It correlates with good outcomes. The other thing that I've been impressed with, Craig, and we've got some early data on this, and certainly we need more data as well. But I've been very impressed with, I showed an image with the patient with frostbite in the presentation. It's very difficult to look at. That patient wasn't so tough because you could see some changes afterward, but most of these wounds you put in the chamber and you see nothing going on visually for treatments on end, several weeks before you start seeing that granulation turn around. And what I have found is we can actually take a pre and post snapshot and look at the delta, the change in the StO2 between pre and post. And what may not be visually striking or visually apparent on the camera is very evident that there's a delta there, that we've made a difference. And sort of serendipitously, we stumbled across this observation that those patients with good outcomes, their early deltas show improvement, whereas the patients that end up going on the amputation and losing their toes to a TMA or even higher, they had really rock bottom deltas. And so I think there's going to be value on both sides, but certainly an area that we're going to need to collect more data on, as we move forward, as you suggested, Craig. So
I thought that was very interesting. Obviously, I don't treat frostbite. First, we don't get a whole lot of that in South Louisiana where I am, but I'm not doing wound healing stuff, more the revascularization component. But again, I thought that's very interesting because, early signals sometimes in medicine are as important as the ultimate data that we get, right? It gives us prognostic information about the direction in which we're headed.
So I got a question. I think I'm going to throw this question at you, Craig, because it's sort of, I think we run out of Q&A questions, which is fine. We're coming up on our time, so maybe we'll close with this one. I think this area of imaging has exploded here over the last 3 to 5 years. I mean, there's new cameras being developed all the time. And I'd like your two-part question for you. We have near-infrared spectroscopy where we can actually visualize, hemoglobin saturation and measure oxygen saturation values. But how about some of the other imaging technology out there, thermal imaging? What are your thoughts on thermal imaging? That's the first question. And the second question is, isn't this something that maybe Kent or one of the other companies out there should start thinking about, is trying to put these technologies together in one camera? So, we're not bringing 3 or 4 devices into the room. What are your thoughts?
Sure. Well, I've used some thermal imaging as a quick screen for venous insufficiency and certain issues with that. And there are thoughts that it may also play a role, thermal imaging, in arterial revascularization. So thermal imaging is using new technology that can allow temperature change detection of as little as 0.1 degree centigrade. And that can be very important because, for instance, in the case of superficial vein insufficiency, often we can see the superficial veins very clearly. We can get an idea what's happening. It's not been worked out quite as well yet for ischemic changes, but I think it's going to have some role, particularly if we're speaking venous insufficiency, because a really good vein study to assess for venous insufficiency on the average takes about an hour. Okay. And in fact, in most hospitals, I would say most venous studies, and when I say most, I'm going to give you an idea, about 99% only tell you clot or no clot. They do not tell you whether or not there is venous insufficiency. And if there is, they don't tell you where it is, ideally, which is what we need. A really good vein study takes a lot of time. Thermal imaging, on the other hand, once again, is very quick. It's one of those 1-minute studies. It can give you a clue. It can also help the technician look at certain areas. For instance, most techs are pretty good at looking at the greater saphenous and small saphenous veins. But when we have other veins that are normal variants, things like anterior accessory or posterior accessory veins, they're not so good. They often miss insufficiency in those vessels. This quick thermal image could help guide them, and perhaps it could save a lot of people from having an hour-long study they don't need if we see nothing there suggesting a problem. So I do think thermal imaging may play a role as we go forward. I don't know if it can ever tell us the same things that we're learning in the arterial side. I think it can be a guide. Have we improved flow at time zero because temperature goes up?
Sure.
But the final arbiter of healing is going to be oxygen saturation. Are we getting red blood cells with oxygen to tissues? Which once we see that that's happening, we know that nutrients are going to get there. We know that the tissues should improve. So I really think O2 saturation is going to, I would be surprised if it doesn't become the mainstream way that we determine ultimately healing, particularly in the ischemic state. I believe that. But I'm really tickled pink about what I've seen here so far with this measure of oxygen saturation, because historically I've tried many things and they were simply not reproducible. And I mean, they were tech dependent. They were dependent upon the temperature in the room, night and day dependent. I could not reliably state at a number I could count on healing. I've been very pleased with what I've seen so far. I hope I continue to see this. And thus far, my experience is limited. I would say only about 400 cases, but it's certainly, no, it's enough. It is enough for me to state that I'm more impressed with this than anything I've used thus far.
That's great.
That's important.
Well, Craig, with those very positive comments, I think we'll go ahead and wrap things up here. We're at the time limit, and you've been very gracious with your time. I certainly would like to thank you, Craig, as my co-presenter here. I've always enjoyed working with you. Great deal of respect for you. You've always been a thought leader in this area, and certainly sharing your thoughts on this technology has been helpful for me and hopefully for others on the webinar. I'd also like to thank your team at New Cardiovascular Horizons. Tom Best, as always, did a superb job putting this together. I'd also like to thank my team at Kent for their work on this, and the collaboration was fabulous, and hopefully we can do some more of these in the future. And I guess lastly, I'd like to thank everyone for dialing in and spending a few minutes with us here tonight. Hopefully you found it valuable and insightful. You know, if you feel that you have some comments that you'd like to share, please send those in. We'd love to hear them. And if you'd like to see more of these in the future, please let us know that as well. So Craig, I'll let you get back to your family and other things tonight. Again, it's just my pleasure to spend some time with you. Thank you so much.
Same here.
Good night, everybody.
Bye-bye.